Hello, dear students. We are moving to chapter 53 with concepts of care for patients with liver problems. And the most important concepts are cellular regulation, infection, fluid and electrolyte balance, which is a priority concept for all gastrointestinal diseases, inflammation, pain, nutrition, another concept, a priority concept in the gastrointestinal system. We're gonna check right now this video about cirrhosis that I want you to be familiarized and to give you a more deep understanding of the disease.
I'm Dr. Smara Ilyas, a transplant hepatologist at Mayo Clinic. In this video, we'll cover the basics of cirrhosis. What is it? Who gets it? The symptoms, diagnosis, and treatment. Whether you're looking for answers for yourself or someone you love, we're here to give you the best information available. Put simply, cirrhosis is scarring of the liver. Anytime an organ is injured, it tries to repair itself. And when this happens, scar tissue forms. As more scar tissue forms in the liver, it becomes harder for it to function. Cirrhosis is usually a result of liver damage from conditions such as hepatitis B or C or chronic alcohol use. The damage done by cirrhosis typically cannot be undone. But if caught early enough and depending on the cause, there is a chance of slowing it with treatment. And even in the most severe cases, liver transplants and new treatments provide those suffering from cirrhosis with hope. Any kind of disease or condition that harms the liver can lead to cirrhosis over time. About 2% of American adults have liver disease, and therefore are at risk of developing cirrhosis. However, those who drink too much alcohol, those who are overweight, and those with viral hepatitis are at a greater risk. Not everyone with these risk factors develops cirrhosis. These are the leading causes of liver disease. A wide range of other conditions and diseases can cause cirrhosis as well. Some include inflammation and scarring of the bile ducts, known as primary sclerosing cholangitis, iron buildup in the body, what we call hemochromatosis, copper accumulation in the liver, which is a rare condition called Wilson's disease, and inflammation from the body's own immune system harming liver cells, known as autoimmune hepatitis. Often, cirrhosis shows no signs or symptoms until liver damage is extensive. When symptoms do occur, they may first include fatigue, weakness and weight loss, nausea, bruising or bleeding easily, swelling in your legs, feet, or ankles, itchy skin, redness on the palms of your hands, and spider-like blood vessels on your skin. During later stages, you might develop jaundice, which is yellowing of the eyes or skin, gastrointestinal bleeding, abdominal swelling from fluid building up in the belly, and confusion or drowsiness. If you notice any of these symptoms, you should speak to your doctor. Since you may not have any symptoms in the early stages of the disease, cirrhosis is often detected through routine blood tests or checkups. If your doctor finds something suspicious, further blood tests may be necessary. These can help identify how extensive your cirrhosis is by checking for liver malfunction, liver damage, or screening for causes of cirrhosis such as hepatitis viruses. Based on the results, your doctor may be able to diagnose the underlying cause of cirrhosis. They may also recommend imaging tests like an MR elastogram that checks for scarring in the liver, or an MRI of the abdomen, CAT scan, or an ultrasound. A biopsy may also be required to identify the severity, extent, and cause of liver damage. Although the damage caused by cirrhosis is not reversible, treatment can slow the progression of the disease, alleviate symptoms, and prevent complications. In cases of early cirrhosis, it is possible to minimize damage to the liver by tackling the underlying causes. For instance, treating alcohol addiction, losing weight, and using medications to treat viral hepatitis and other conditions can limit damage to the liver. Once the liver stops functioning, an organ transplant may be an option. During a transplant, surgeons remove the damaged liver and replace it with a healthy working liver. In fact, cirrhosis is one of the most common reasons for a liver transplant. You and your medical team will need to assess if you're an appropriate candidate through a transplant evaluation. Surgery is a big undertaking, one that brings its own risks and complications, and it should always be a decision between you, your family, and your doctors. If you're concerned about your risk of cirrhosis, talk to your doctor. Life with cirrhosis can be challenging, but with the right information, the right medical team, and the right treatment, there's reason to be encouraged. Health professionals learn more and more every day about the conditions and diseases that damage our livers. Studies investigating new treatments that can slow and even reverse the scarring that leads to cirrhosis are currently underway. For those with cirrhosis, the future is brighter than ever before. If you would like to learn even more about cirrhosis, watch our other related videos or visit mayoclinic.org. We wish you well.
Thank you so much. So let's continue our lecture. The liver, as the largest and one of the most vital internal organs, the liver performs more than 400 functions and affects every body system. Common problems of the liver affect cellular regulation, nutrition, and fluid and electrolyte balance. Liver diseases range in severity from mild hepatic inflammation and infection to chronic end-stage cirrhosis. Many of these problems can cause pain or discomfort. Cirrhosis is extensive, irreversible scarring of the liver, as the lady explained already, usually caused by chronic reaction to hepatic inflammation and necrosis. This scarring process directly impairs regular regulation. The disease typically develops slowly and has a progressive, prolonged, destructive course resulting in end-stage liver disease. So the pathophysiology is characterized by widespread fibrotic scar bands of connective tissue that change the liver anatomy and physiology. Inflammation caused by either toxins or disease results in extensive degeneration and destruction of hepatocytes, which are the liver cells. As cirrhosis develops, the tissue becomes nodular. These nodules can block bile ducts and normal blood flow throughout the liver. Impairments in blood and lymph flow result from compression caused by excessive fibrous tissue. In early disease, the liver is usually enlarged and firm. As the pathologic process continues, the liver shrinks in size and becomes harder, resulting in decreased liver function over weeks to years. Some patients with cirrhosis have no symptoms until serious complications occur. The impaired liver function results in elevated serum liver enzymes. Cirrhosis of the liver can be divided into several common types, depending on the cause of the disease. You have the post-necrotic cirrhosis caused by viral hepatitis, especially hepatitis C, and certain drugs or other toxins. Leonard's or alcoholic cirrhosis caused by chronic alcoholism. Biliary cirrhosis, also called cholestatic, caused by chronic biliary obstruction or autoimmune disease. Now, complications of cirrhosis. In compensated cirrhosis, the liver is scarred and cellular regulation is impaired. But the organ can still perform essential functions without causing major symptoms. When we talk about cellular regulation, please consider the fact that the liver is the only organ that regenerates. So where there are certain imbalances, the liver can, at some point, can heal, right? But there is a limit. That's where cellular regulation impairment becomes in the horizon, right? Because since the poor liver is getting so much toxicity, the rhythm of damage versus healing is not the same. In decompensated cirrhosis, liver function is impaired with obvious signs and symptoms of liver failure. The loss of hepatic function contributes to the development of metabolic abnormalities. Hepatic cell damage may lead to these common complications: portal hypertension, ascites and esophageal varices, biliary obstruction, hepatic encephalopathy. Portal hypertension. A persistent increase in pressure within the portal vein greater than 5 mmHg, which is millimeters of mercury. It results from increased resistance or obstruction, blockage of the flow of blood through the portal vein and its branches. Blood flow backs into the spleen, causing splenomegaly, spleen enlargement. Veins in the esophagus, stomach, intestine, abdomen, and rectum become dilated. Portal hypertension can result in ascites, excessive abdominal peritoneal fluid, esophageal varices, distended veins, prominent abdominal veins, and hemorrhoids. Ascites and gastroesophageal varices. Ascites is the collection of free fluid within the peritoneal cavity, caused by increased hydrostatic pressure from portal hypertension. This is combined with the inability of the liver to produce albumin because of impaired liver cell functioning. The serum colloid osmotic pressure is decreased in the circulatory system. The patient may have hypovolemia and edema at the same time, okay, because the fluid is moving out of the circulatory system. That is why there is hypovolemia, and there is edema in the extracellular space, right? Because of the fluid is moving outwards. And since there is not enough albumin, which is the magneto to keep the fluid in the circulatory system, that's why the fluid is transferred to the extracellular space. Massive ascites may cause renal vasoconstriction. This results in sodium and water retention. Sodium and water retention. Where water goes, sodium goes. Where sodium goes, water follows. As a result of portal hypertension, the blood backs up from the liver and enters the esophageal and gastric veins. Esophageal varices occur when fragile, thin-walled esophageal veins become distended and tortuous from increased pressure. Varices occur more often in the distal esophagus, but can be present also in the stomach and rectum. Decreased prothrombin production places the patient with cirrhosis at risk for bleeding. Bleeding esophageal varices are a life-threatening medical emergency. Severe blood loss may occur, resulting in shock from hypovolemia. The bleeding may present as either hematemesis, vomiting blood, or melena, black tarry stool. Any activity that increases abdominal pressure may increase the likelihood of a variceal bleed, including heavy lifting or vigorous physical exercise. Okay, and here we can see the jaundice as a result of liver dysfunction, and the video explained jaundice is going to appear basically at a very advanced liver disease, cirrhosis stage, right? Let's continue. Splenomegaly results from a backup of blood into the spleen. The enlarged spleen destroys platelets, causing thrombocytopenia. Now, when we read the enlarged spleen destroy platelets, we have to remember that the spleen is the organ that is going to produce a balance. It's going to try to make a balance in the platelets numbers, right? But when the spleen is destroyed, platelets causing thrombocytopenia, that is an issue already, an increased risk of bleeding. Thrombocytopenia is often the first clinical sign that a patient has liver dysfunction, of course, because this condition is causing the spleen to work the wrong way. Biliary obstruction. In patients with cirrhosis, the production of bile in the liver is decreased. This prevents the absorption of fat-soluble vitamins like vitamin K. Without vitamin K, clotting factors 2, 7, 9, and 10 are not produced in sufficient quantities, and the patient is susceptible to bleeding and easy bruising. So when we talk about fat-soluble vitamins, I want you to remember the mnemonic ADEK, A-D-E-K. So it's vitamin A, vitamin D as in David, E as in elephant, K. ADEK. Those are your vitamin-soluble, your fat-soluble vitamins. Let's right now watch another video about the gallbladder and biliary tree, so we can understand better the pathophysiology.
The gallbladder is a reservoir that is responsible for storing and concentrating bile that's produced by the liver. It's shaped like a slightly elongated pear and sits underneath the liver, as you can see here. We can also see how the gallbladder lies slightly superior and lateral to the duodenum and pancreas. The gallbladder has the capacity to store around 30 to 60 millilitres of bile, and it's during periods when the individual is fasting that the gallbladder is more filled. The gallbladder is covered by a thin layer of peritoneum and is connected to the common hepatic duct via the cystic duct. The gallbladder itself can be divided into 4 parts: the fundus, the body, the infundibulum, and the neck. Regarding the biliary tract,